we now move on to one of the best anterior segment surgeons in the Asia-Pacific region, and that is none other than Shamira Perera, who is director of the anterior segment surgery at the Singapore National Eye Center, millions of dollars in research grants and 8 patents. And he'll be covering the difficult part of today's symposium, what can go wrong with MIGS and the rescue operations. So over to you, Shamira.
This one? लगा दी HDMI.
So while we are waiting, one question for Steve. So Steve, if you have a patient with early glaucoma and cataract, so what would be your go-to procedure for cataract surgery? Would you combine with the MIGS, and if so, which MIGS?
Yeah, so I'll first talk to the patient and say, do you mind being on your glaucoma medicines? If they say no, then I'll say, well, you know, we can just do a cataract alone. If they say, yeah, I'd like to try to get off 1 or 2 of the medications, and they're on a blood thinner, then I'll probably do a stenting procedure, as we just heard. If they're on no blood thinners or anything like that, then I usually do a goniotomy with a Cahoog blade.
Okay, thank you very much for the kind introduction, Tanuj, and the organizing committee for inviting me here today. Now, you've all seen some examples of excellent surgeries, but of course, there's always things that can go wrong, including my slides. Can I advance the slides? Okay, here we go. These are my financial disclosures. Now, we all know that when something can go wrong, it probably will. And if you're not getting any complications, you're simply not doing enough surgery. I've limited my talk to basically the trabecular meshwork MIGS. This is what's being performed in India at the moment, and those cutting procedures, the stenting procedures that you're doing, I'll be going to how to deal with the problems that can occur and how to get out of a difficult situation. Generally speaking, the complications are low for all of these microinvasive glaucoma surgeries, with the numbers occurring in the few percentage points, only up to about maximum 13% in terms of PS formation. Here's one of the examples of something that can go wrong with a Hydrus device. You can see the Hydrus device going in, but what happens later on when you pull the injector out? You can see in this particular case, there's been a DM detachment. It's quite large. Often happens when you're pulling out the device. You can put air into the eye, create a bubble, leave it for 6 minutes, and then remove half the bubble, which will allow it to reform. Alongside this, there's always the worry of endothelial cell loss. And as you can see in these studies, that the CyPass was the one who had the highest amount of endothelial cell loss and led to its being withdrawn from the market. And what was happening even worse was after the 2-year time point, the amount of endothelial cell loss got worse. And that's the reason why it was removed. In most of the other MIGS, fortunately, the endothelial cell loss is very low and about 1% per year once the device is in. But of course, with the larger Hydrus, there can be difficulties with putting it in, and it may lead to an increased cell loss at the initial stages. Here's an example of a diving Hydrus. You can see it's going down into the area behind the iris and it's lost. So you have to withdraw this. You can't leave it in that position. It might cause problems with UGH syndrome, but also with removing it, you can cause a cleft or even an iridodysis. So you just remove it back as you put it in, and you can move around a few clock hours and then reinsert it. Here's another example of one of the complications that occur with a Hydrus, which is an in and out Hydrus. And you can see it's gone in but out. This is actually a left-handed surgeon putting it in, and it's gone in but come out. And this happens when you've got the eye over-inflated, so the trabecular meshwork is pushed together, so it goes in but also comes out. Also, you can imagine in eyes where there's an extreme myope, the curvature is not quite right, and you can see here the curvature doesn't match up. So again, this nitinol-based device doesn't expand or contract very easily with changes in curvature, and this can lead to problems with this in and out. This is a complication of mine. During a Hydrus insertion, I managed to rip off 40% of the iris. You can see a massive 40% iridodysis here. The patient was moving, as a patient with learning difficulties and Tourette's. And you can see even the difficulties I'm having putting this iris back together again using 3 Hoffman pockets and a tenoproline needle, grasping the edge of the iris and reinserting it back to where it should be. You can allow it to hang back, but of course, the difficulties I'm having here with this moving patient put me through a lot of stress. But in the end, you can see it does actually look quite reasonable at the end with a round pupil. But of course, I've not put the hydrus in, I've taken it out, and I need another glaucoma surgery, like a tube, later on. Another one of the difficulties you can have with complications is the formation of PAS. And you can see the occlusion rates of G1 are very low in the POAG eyes, but in PACG it can go up very massively. Interestingly, the results of hydrus in PACG are actually very similar to POAG, and there's an example here of me putting a hydrus in behind where the PAS is here, in the only one quadrant where it's able to put it in. I then, once popping it into the right position, I'm able to peel down the PAS here, revealing the device in the angle. In the end, the patient did well, but is it because of the phaco, is it because of the hydrus, or is it because of the GSL? No one knows. Again, be careful with these situations because the reoccurrence of PAS is still very, very high. And if the PAS comes up to your inlet for the hydrus, it leads to a larger spike in IOP rather than if it comes up to the 3 windows. These are some things that can go wrong. You can see the DM detachments, diving hydrus, and iris to the windows that can occur. Here's an example of an iStent in too much of a superficial insertion. Here you can just flip it out with the trocar and reinsert it by threading it back in again. But of course, remember, you've only got 2 stents and 4 shots with this, so you have to be judicious with the amount of shots that you use. Once you've got it reinserted, back in the needle, you can do that, by the way, inside the eye or outside the eye. I actually prefer doing it outside the eye and then reinsert it a few clock hours down the line. So it is definitely possible to do this, and especially with the iStent Infinite, which you've got right now, when you've got infinite number of shots, we should actually be putting it in into the best position. And if it's not quite right, the onus is on us to remove it and put it in correctly. Here, there's quite a lot of striae being formed, but it goes in a nice position there. Here's some examples of what can go wrong with some of the iStents. Here's a very shaky surgeon here, but of course, once you pop it into the right position and withdraw straight out, actually it looks quite decent. Moving across 2 clock hours, they're much more confident for their second insertion, and it goes in. And then when they come out, as long as you come out in a perpendicular fashion, it looks quite nice. Now, this example of something called needle bias or sideways tilt. You can see the needle just in the groove, the cutout, and it's being pulled to one side. So you've got to be careful with that because a stent doesn't go in easily. This one's over-inserted. And even this one, you can see the needle is bending as the inserter is being pulled to one side and the other. Fortunately, this one goes in okay. There's a plume of blood. Here again is an over-insertion. This is because you can't really see the area very well, and there's striae on the cornea, and there's no good en-face maneuver here, so you can see the stent is going in too far. This has largely been alleviated by the new versions of the iStent with the iStent G2W. You can see these examples of a good iStent G1 inserted in the canal on the ASOCT, but also some poorly malpositioned ones with the G2 here above and below and inserted too far in as well. The improvements in design have led to a wider stent and a wider flange, so that means it's harder for it to get over-inserted. And even the materials are better now with less trocar bias available, and the materials are much stronger, so it stays steady when you put it in. Here's an example of a good G2W with reflux, showing you that it's harder to get that over-insertion. Here one goes in quite nicely, and the neck of the device is in the canal. And a nice wide flange this time outside. You can see some blood refluxing outwards as well. This is one of the most dramatic complications that you can get with a iStent. It's called pinball wizard. One stent goes in quite nicely. Second one is definitely under-inserted, and you can see that there's too much coming out. And when you do the IA, it starts to pull out a little bit. See it moving? And then in the end, it comes out completely and shoots around in slow motion around the anterior chamber. Eventually settles on the iris. You can pick it up with a micro forceps, rethread it, and put it back in again. So here I am removing it and rethreading it outside the eye. Actually does go in quite nicely in the end, reinserted. Whilst much has been made of the complications that can occur with the large stripping procedures, many people never have seen something as large as this. This is a post-op high femur occurring in a KDB eye. You can see there's an endocapsular high femur. And actually, this is a testament to the fact that it actually does work, that the blood drained from in front, but didn't drain from the back after a long time. I didn't YAG this, I left it alone, it did go away by itself. Here's iridialysis occurring with the KDB. And you can see when the KDB is being used to the side, it's off the screen, you notice keep your devices in view. And here you can't see what's going on. And when the surgeon comes out, they can see they've actually caused a small sarcoidosis cleft. You'll see that when they do the IA. But in this case, it was quite small. Can you see here? Maybe 1 and 2 clock hours. It's okay to leave it. It's not going to cause much problems. But you can see the nice cleft that's been formed, the removal of tissue in the gonioectomy by the KDB. Some of the other complications that can occur with GAT, of course, are high femur. This unusual complication where there's a leakage of blood if you stand on your head or you valsalva, and the blood can come out from the canal into the AC, causing intermittent blurring of vision. Fortunately, the complications after trabectome are also similar to those after some of the other MIGS procedures. Of course, with GAT, the limitation is, of course, the formation of PAS in the longer term. It's quite a destructive procedure, and the high femur that occurs is pro-inflammatory, and also you end up with these small PS, which it ultimately limits the efficacy of the procedure. So in general, it's very important that you're listening to this and learning the ways of dealing with complications, because you will find them if you do enough surgeries. The learning curve for TM MIGS is transferable. So actually, when you learn the procedures to deal with these complications, let's say being even putting an air bubble in, or repairing a sarcoidosis cleft, or a iridodialysis, they can be used in your other surgeries as well. I think the most important thing to say is these are taken from over 1,000 different surgeries, and I think that generally speaking, these devices are very safe. But it is important to be able to deal with the upcoming complications that can occur and to set the patient's expectations correctly. I've tried all the ways of creating shortcuts with these MIGS, and the one thing I've learned is you must stick to the rules on this. So thank you very much for your attention. Hope you don't have any nightmares.
Thank you, Shamira. That was quite a scary presentation. Thanks for the warning.